Okay, moving on to part 2 of therapeutic apheresis. There's a little bit of a kidney theme, so that's why I thought this would be cute. Instead of Hello Kitty, it's Hello Kidney. So we're going to continue talking about plasmapheresis and some diseases such as cryoglobulinemia, Wegener's, Goodpasture's, and FSGS. Then after that, we'll discuss photopheresis and talk about the principles, how does it work, considerations, how do we prepare the patient, some complications that we might run into, and then a few diseases treated by photopheresis, treated with photopheresis, cutaneous T-cell lymphoma, and the leukemic form of that, Sézary syndrome, graft versus host disease, particularly after bone marrow transplant, and lung transplant rejection with bronchiolitis obliterans syndrome. So we'll continue with plasmapheresis and then talk about photopheresis. So what is a cryoglobulin, right? A cryoglobulin is an immunoglobulin that reversibly precipitates below body temperature. So they reversibly precipitate below body temperature. And here's a picture of one. When you take the patient's serum and then put it in the refrigerator and then centrifuge that, down here is what the cryoglobulins are. And so contrast a cryoglobulin with a cold agglutinin. Okay, don't confuse these two. A cold agglutinin is an autoantibody to a red cell antigen, right? It has red cell specificity. A cryoglobulin does not have any red cell antigen specificity. It simply precipitates when it gets cooler. And this is what it can look like on a peripheral smear. You have these kind of acellular, amorphous blobs, usually that stain purple. It can also, in other cases, look kind of like if you took a bunch of dirt and threw it on the slide in between the red cells. It could also manifest that way. So contrast this appearance with a cold agglutinin. You'll have red cell agglutination as the primary feature. You won't have all this acellular gunk. And the pathophysiology is that you have these cryoglobulins that then precipitate and then they'll aggregate, right? They'll gum up the works in small vessels and then activate complement and recruit leukocytes to the site. So that's why what's often involved is the skin of lower extremities, right? The coolest part of the body will often be affected, and then how are they affected? You can see purpura, arthralgias, sensory neuropathies, and then if it gets worse, glomerulonephritis, and then in the worst cases, a systemic vasculitis. And how on earth do these things form? It's currently not well understood, an unclear mechanism. One hypothesis is that you have this B cell activating factor that can stimulate your B cells. And then another idea is that you have IgG-bound hepatitis C virus that drive clonal expansion. So in hep C, the cryoglobulin is actually a complex, right? So a cryoglobulin could be solely comprised of antibodies. In other cases, it could be comprised of antibodies and antigen complexes. So in hep C, it's a complex of what? It's a complex of IgG against hep C, number one. Number two, the hep C particles, the hep C virion itself. And number three, this rheumatoid factor, an IgM that's targeted against IgG. So if you combine all these ingredients, you'll get the cryoglobulin in hepatitis C. And so it's worth discussing how to preserve the lab samples, meaning it's worth mentioning not so much the disease process in the patient, but how do we do the cryoglobulin test in the lab, right? So this is a little bit of a digression into immunology, but it's worth talking about because it's a popular subject. So it could be called the cryoglobulin test or the cryocrit. And then usually how this is used is I just want to know, is it positive or negative? Does the patient have cryoglobulins or not? If it is positive, then what I'll do after that is an IFE, immunofixation electrophoresis, and we'll get into why we do that. it give you a hint about the etiology. In some cases, the cryocrit as a number, right? The like kind of an attempt to quantify how many cryoglobulins are there. I've seen some cases where the clinician insisted that we get cryocrits before and after plasmapheresis. We did that for a few procedures, and in many cases, the cryocrit went up after plasmapheresis instead of down, which sounds wacky, but as soon as you know how the test is done, you could appreciate how crude the test is and how that number is. You can't really rely on that number for much of anything. I just think of it as positive, negative, not worrying about is it 2%, is it 5%. So in addition to the crudity of the test, we'll also emphasize that specimen processing is vital. What do I mean by that? You have to keep the specimen warm. You have to keep the specimen at 37 degrees from pre-collection, right? Even warm up the tube before you fill it up. Right after you collect the specimen, keep it warm, and throughout the transport process. All the way up until the initial spin that I'll show you. Keep it warm the entire time. Why do we want to do this? Well, think about it. This is cryoglobulins, right? They precipitate at cooler temps. So we want to prevent precipitation of these cryoglobulins into the serum before we separate the serum, right? Because those pictures I was showing you, it was just the serum. There were no cells there. So we don't want to lose any cryoglobulins in the cellular component that would cause a false negative. Does that make sense? So once the serum is separated, then we're going to place just the serum by itself in the refrigerator for at least several days. And then it's a very crude test. We just keep looking. Is there anything that has precipitated? Is there anything that has formed in this cold serum? So if we see something that is precipitated, then what we'll do is we'll centrifuge until it's maximally packed. And what I mean by maximally packed is that on 2 consecutive centrifugations, the number stays the same. Like you can't pack it anymore. You can't make it any more dense. So you could use your IFE to give you a hint about the etiology. It doesn't tell you the etiology, but it could help point you in the right direction. So if you do an IFE and then you find a monoclonal gammopathy, then that leads you in the direction of a neoplasm, like myeloma or Waldenstrom's. If you see polyclonal IgG and monoclonal IgM, then that is, as we'll see, going to point you in the direction of Hep C, like we talked about in that one image. It would point you away from neoplasms, right? And then type 3 is polyclonal IgG, just like type 2, but you also have polyclonal IgM. And about 80% of patients that have one of the mixed, have some component of polyclonal, either type 2 or type 3, they end up having Hep C. They end up having hepatitis C. But that's not the only cause. Other causes include autoimmune diseases like lupus, Sjogren's, and rheumatoid arthritis. Plasmapheresis is usually bridging therapy, right? It's not like it's definitive therapy. It's just that it removes very quickly a lot of the cryoglobulins that are damaging the patient. And it's usually something like 3 to 8 times, roughly, on a Monday, Wednesday, Friday schedule. So we want to follow the patient's clinical response. That will help us determine, should we keep going at the same frequency or taper it, etc. Again, following the cryocrit is not useful. Don't be lured into that. And rituximab is often helpful, particularly if it's an autoimmune disease or if it's, say, Waldenstrom's. And then you want to treat the underlying disease, especially if it's, as a broad concept, yes, and especially if it's Hep C, you give them antiviral therapy. Oh, yes, that's very fascinating. So now we're going to talk about GPA, also known as Wegener's granulomatosis with polyangiitis. This is an autoimmune disease with an unknown etiology. It's characterized by necrotizing granulomatous inflammation, pauci-immune vasculitis, and small and medium-sized vessels. And a very common manifestation is sinusitis. So what they often call like saddle bridge sinusitis, because there's, I guess, a little saddle here on the nose. And then, like many other ANCA-associated vasculitis diseases, you could see pulmonary infiltrates, diffuse alveolar hemorrhage in the worst case, and you could see rapidly progressive glomerulonephritis. So this is one of what is often called a pulmonary renal syndrome. So it often affects the lungs and kidneys. And Wegener's or GPA is often C ANCA positive. And very often you see an antibody against PR3, proteinase 3. Plasmapheresis helps regain kidney function in Wegener's, so it helps in severe kidney disease. Plasmapheresis also, of course, helps with diffuse alveolar hemorrhage. The treatment schedule is typically 7 procedures in 14 days. So 7 procedures in 14 days. And if they have if they have diffuse alveolar hemorrhage, right? If they have lung bleeding, then we'll usually do 3 daily procedures initially. So this has really nothing to do with Goodpasture's, but I just thought it was cute that, you know, you got Napoleon Kite and is expanding the empire, reading about it in study hall. I don't know. That's what we're doing, studying, right? Goodpasture's, also known as anti-glomerular basement membrane or GBM disease, is an autoimmune disease, and you have antibodies against type 4 collagen. And then for the ANCA, if you do ANCA testing, it's usually negative, but you can sometimes see P ANCA positivity when it is positive. And then you also often see antibodies against MPO in Goodpasture's. So it has somewhat similar manifestations to GPA or Wegener's, in that it could affect the kidneys as a glomerulonephritis, or the lungs, worst case, as a diffuse alveolar hemorrhage, but you can have a milder form like hemoptysis. Usually you do not see sinusitis that you saw in GPA or Wegener's. Less commonly, you could see renal only in anti-GBM disease, and even rarer than that, lungs only. So just like all the other ANCA vasculitis diseases, including GPA and Goodpasture's, plasmapheresis helps most patients with diffuse alveolar hemorrhage, but Goodpasture's is a little bit exceptional, right? This might be some pimp questions. That in Goodpasture's, plasmapheresis usually does not help regain kidney function if the patient's already dialysis dependent. If, however, they have kind of moderately damaged kidneys, right? They're not normal, but they're not dialysis dependent. Plasmapheresis can help recover kidney function if the creatinine is less than 6. And that's all I had to say about Goodpasture's. Now this is a little bit goofy, but I like it. This is supposed to represent FSGS, right? And hopefully you'll see why in a few minutes. There's this poorly understood permeability factor that leads to proteinuria. And so it's worth keeping in mind that FSGS is not like many of the diseases we've talked about. It's not a typical autoimmune disease. So what happens is you have this circulating permeability factor that can cause direct podocyte injury. So here's your podocyte, here's your glomerular basement membrane, and so it could basically cause the podocytes to be injured and to be unanchored from both the GBM and from neighboring podocytes. And so once you have podocyte detachment, that can lead to proteinuria, right? You can see how protein can make its way through these gaps and cause proteinuria. There is about a 40% recurrence rate of FSGS after transplant. So it's relatively common after transplant. And for unclear reasons, probably because we're selecting for a specific patient population that has this permeability factor, plasmapheresis helps post-transplant FSGS, but typically it does not help native FSGS, native kidney FSGS before transplant. And most patients see an improvement in their proteinuria from the plasmapheresis. And a common treatment schedule is something like 3 times a week for 3 weeks, and then taper after that. As you can imagine, the urine protein level guides the plasmapheresis schedule. Now moving on to something involving drugs. How does photopheresis work? Photopheresis works by step 1, you remove some blood, and then you put it in centrifuge and separate out red cells, white cells and platelets, and plasma. And what we're targeting in photopheresis is the white blood cells. So a small percentage of your total white blood cells are put into the machine, and then all the other blood, components of the blood, go back to the body. And then these collected white cells are treated with something called methoxylin, or 8-methoxysorolin. So as we'll see in a minute, this is a photosensitizer. So we put the larger class is called a sorolin, so we'll put a photosensitizer on these white cells. That's step 1. And then step 2 is expose these medicated white cells to UVA light. So we're adding a photosensitizer, and then we're adding light. So in my mind, we're kind of like sunburning these white cells. We're inducing DNA damage, as we'll see. And then these treated white cells are then returned to the body, so they cause an immune response. And a picture of this, we have our centrifuge, and then we have our tanning bed, right? This is the UVA light source that is shined on the white cells. This is red colored because inevitably red cells are admixed because it's right on the red cells and the white cells are right next to each other when you separate out the layers. Exactly. This is hilarious, actually. If you go into YouTube and type, pug, pool, sleeping, snoring, whatever, because there's a video of the pug sleeping and snoring, but then it ends. I won't tell you how it ends. You should see for yourself how it ends, but it's worth looking at. Nothing bad happens, don't worry. It's hilarious. So you add the sorolin or Uvadex, and that will intercalate into the DNA. And then when you do the second step and add UVA light, those photons will cause DNA adducts between the T's and the A's when they're diagonally across from each other. This will increase susceptibility to apoptosis. We're using heparin for photopheresis instead of citrate. The main rationale for this is if we were to use citrate, remember we're sending a bolus of fluid at the end. The treated white cells that we collected, we're sending them all back at once. So if we were to use citrate, the patient would get a large bolus of citrate and their calcium could drop dangerously. So we use heparin as an anticoagulant instead. So in general, photopheresis is contraindicated in patients with a history of HIT. Untreated, it's contraindicated. There's no replacement fluid needed in photopheresis, right? We're removing a small percentage of white cells, treating them with sorolin and UVA light and sending them back. 24 hours after the photopheresis procedure, you want to minimize exposure to sunlight. If you have to be in the sun, wear sunscreen and wear these very fashionable UVA protective glasses. We could use photopheresis for 3 key diseases we're going to talk about. One is cutaneous T-cell lymphoma, also known as mycosis fungoides. And you could also use it for Sézary syndrome, the leukemic variant of this disease. Keep in mind that this disease is generally incurable, and what we're doing is palliative, right? It's treating symptoms, as we'll see. It's not like chemotherapy. It's not meant to be curative. Photopheresis is palliative treatment for the erythrodermic phase of Sézary syndrome, which is defined as greater than 80% involvement by the body surface area. So usually the treatment schedule is we'll do 1 cycle, and 1 cycle is defined as photopheresis once on 1 day, and then again, usually the next day. And then the usual treatment schedule is to do 1 cycle, something like every 2 weeks, up to every 4 weeks, and then taper with the patient's response. And you have a complete remission, not of the disease, but of the erythrodermic phase. They get out of the erythrodermic phase as defined as 80% body surface area in about 1/3 of cases. And there's at least partial improvement within 6 months in about half patients. about half the patients. We can also use photopheresis for graft versus host disease after a bone marrow transplant, after a stem cell transplant, which is manifested in usually skin involvement, GI, liver, lungs, and eyes could be affected. Usually many tissues can be involved. And what we do is useful either for acute graft versus host disease, but we most commonly use it in chronic graft versus host disease. But it could be effective in either circumstance, both before day 100 and after day 100. And about 50%, this is a very rough response rate, and it varies widely by organ system. Typical schedule is we're going to do one cycle, 2 days of photopheresis each week for 4 weeks, and then after that, every 2 weeks for 4 cycles, and then every month for 4 cycles. And then finally, cellular lung rejection with bronchiolitis obliterans syndrome. So this is cellular rejection, not antibody-mediated rejection. And this is relatively common. About half of lung transplant recipients develop BOS within 5 years after the transplant. And keep in mind that this is a physiologic, not a histologic diagnosis. I mean, you can glean a lot from a lung biopsy, but the diagnosis of BOS in particular is defined as you need a decline in the expiratory flow rates, meaning your FEV1, that's otherwise unexplained and lasts for at least 3 weeks. So that pulmonary function test result is consistent with BOS. And so some places use a similar schedule that we saw before with graft versus host disease, do 4 weekly cycles, then 4 every other week cycles, then 4 monthly cycles. Or you could do, instead of doing the 4, you could do the 5. You could do 5 weekly, 4 every other week, then 3 monthly. And then the response rates, roughly 50%, see a slower rate of FEV1 decline. So they continue to lose lung function, but not as quickly. About 25% actually improve, actually regain some lung function. And about 25%, you don't see any observable benefit. And that's all I have to say about Therapeutic Apheresis Part 2. So remember to do the questions, make sure that you've paid attention and learned something.